Everybody, welcome to our second case presentation.
This case presentation is on cholesterol granulomas. This report was found from the American Journal Case Reports and is by Randoljic et al. Of 2019. We chose this study for a couple of different reasons. We thought this was a really unique case of cholesterol granulomas that showed a case of mild hearing loss. In addition, we thought that it showed the importance and the use of just imaging and surgical intervention for the treatment options of this individual. And it also showed a great interprofessional collaboration and how very different professions work together for the benefit of this individual. So a little bit about the case history. This is a 64-year-old male. We don't really have any other particular characteristics of this male. However, some past medical history includes hyperlipidemia, which is abnormally elevated levels of any and all lipids, including fats, cholesterol, or triglycerides, which are found in the blood. He also has a history of diabetes, congenital profound sensorineural hearing loss in the left ear. And that's an important note to remember, that he already had this profound hearing loss within his left ear. Some of the initial presentation that he showed at this time was an acute and progressively worsening hearing loss of a 2-month duration within his right ear. So now he has hearing loss occurring within his right ear. Most likely he went to an ENT for these initial presentation. However, it did not specify it in the study. Here is his preoperative audiogram. As you can see in his left ear, there's his congenital profound sensorineural hearing loss. So that has always been there. Whereas his right ear, now he is showing a mild sensorineural hearing loss. It's also important to note, and they even circled it on his audiogram, that he has an 88% for his WRS scores, along with a normal TIMPs.
So upon a physical examination, they decided to go ahead and do head impulse testing, or HIT, and it showed as a positive result on the right side. And so what does this mean? We're assessing the angular vestibulo-ocular reflex from the horizontal semicircular canal, and therefore also assessing the superior vestibular nerve function in response to small amplitude, high acceleration, rotational head impulses. So people with a vestibular hypofunction may generate these corrective saccades or eye movements after the head is quickly rotated toward the affected pathological side. And so that's considered a positive hit. So we have a positive hit on the right side, which is suggesting that something might be going on that's affecting either the horizontal semicircular canal or the superior vestibular nerve function. And so we see that kind of lines up with this new presentation of mild sensorineural hearing loss in that right ear. And so what now? What should we do? Well, what these people decided to do was order some imaging. And so they went ahead and ordered a CT scan and MRI to see if they could gain any information on what might be going on retrocochlearly. And so the results showed through computed tomography, the CT scan, that there was an osteolytic lesion that closely opposed the right petrous internal carotid artery. So osteolytic is referring to a dissolution of the bone or loss of calcium in the bone. So this dissolution of the bone in this lesion is closely opposing the right petrous internal carotid artery. And this artery is supplying some blood flow to parts of the ear, and this could be contributing to the sensorineural hearing loss that we're seeing. The magnetic resonance imaging, or the MRI, revealed a well circumscribed expansile lesion within the right petrous apex. Well circumscribed is referring to a contour that is clearly defined, and expansile refers to something that is capable of expanding. And so we're seeing that on the MRI, it's well outlined. You can see the lesion very clearly, and it looks like there might be room to grow within the right petrous apex that they find it in. The lateral margin of the lesion is protruding into the right petrous canal, and the petrous segment of the internal carotid artery is bowed interiorly. So this is a lot of good information they're getting from these images, and it'll help them really pinpoint where in the skull the granuloma is, and so they can go forward with any procedures or future imaging.
Here is the imaging that was found from the preoperative MRI images. As you can see, they show a lot on them, but we're really looking for where is that lesion. Again, we're looking for that mass within the right petrous apex. So if we would look closely enough, we can see that there is a pretty substantially large mass right there. So that is very clearly marked on this MRI image. The CT images were also conducted, however, they were not shared within the study. Here is just the diagram of the ear and the internal carotid artery, just for further explanation of where this tumor may be lying. So again, on the left, you can see this would be the ICA and the possible location along with this other view of the artery. So this can severely impact the functioning of the ear along with just the blood flow that the ear is getting in itself.
So based on all this information, putting together the positive hit, the imaging that they found, this mass, we're suspecting, as I said, a cholesterol granuloma. And so to deal with this, they decided they were going to order a surgical procedure, the name of which is endoscopic endonasal transsphenoidal surgery. And this is to the right petrous apex, and they would be using an image guidance system to figure out where they should perform the surgery within the skull. And so I have an image of what the surgery looks like. Endoscopic referring to the endoscope that goes in the nose, endonasal, and all the way back toward the sphenoid, so transsphenoidal within the sphenoid, crossing it. And so they go in there to reach the granuloma, but the surgeon must be really diligent in navigating around the critical structures in this area, such as the internal auditory canal, the facial nerve, and the internal carotid artery. And so for the surgery, a neurosurgeon and an ear, nose, and throat doctor are working together to perform this specialized surgery. Together, they work comprehensively to provide care for brain and sinus related issues before, during, and after the surgery. So they're working together really well to make sure that they're getting just the lesion, and it's not as invasive of a procedure as a usual transcranial surgery would be.
All right, so what happens next now that they've had this surgery? So after the surgery, the patient did not encounter any post-operative complications. So that's great. His hearing, even in the right ear, restored to back within normal limits. And the MRI imaging demonstrated a resolution of this lesion. So some of the post-operative complications that are very common with this type of procedure is a transient or delayed nosebleeds, also known as epistaxis. Um, this was not found to occur with this patient, which is great for the post-operative. And here is just the audiogram that was taken. Again, in his right ear, all of the hearing was restored to within normal limits. It is also important to note that the WRS score also went back up from 88 to 100%. And finally, here is that post-operative MRI image. And if we recall where that lesion was, right in that right petrous apex, I don't really see where that lesion would be anymore. It's quite massive previously. So it just kind of is gone.
Yeah, they did a good job.
Yeah.
So, for some further discussion about cholesterol granulomas, generally they are growths that are comprised of fibrous connective tissues that house fluids, chronic inflammatory cells, lipids, and cholesterol crystals. And so these cholesterol crystals are formed during anaerobic blood degradation. And this triggers an inflammatory response that will start the production of the growths and the connective tissue that houses all those particles, resulting in the cholesterol granuloma. This is the most common primary lesion of the petrous apex, and it's generally found within middle ear spaces and mastoid air cells. And the interaction these granulomas can have with nearby cranial nerves might cause a number of different neurological symptoms. Generally, they're not known to cause hearing loss, but as we see from this case study, it's definitely a possibility, as we did see the presentation of some mild sensory neural hearing loss. Treatment, usually they used to do transcranial surgical procedures in the past, but this had a lot of risk of damaging the auditory structures and nearby structures like the arteries in the bone. So it also resulted in difficulty observing the patient's post-operative course, whereas it's now done via endoscopic approach whenever it's possible, which is much less invasive. And as we see, it can preserve or restore hearing to its previous state. Um, so that's a big step forward in the treatment of these cholesterol granulomas. Imaging is really important in this study specifically because both of these imaging techniques work together to um, identify the etiology. So we had the magnetic resonance imaging, the MRI, which is really sensitive to observing the different tissues of the brain. And so as you saw on the imaging, it was really well outlined. You could see the tumor or the granuloma rather pretty clearly. And so MRI was really great for that. And it's also great for pre and post operatively comparing. As you saw, the lesion wasn't there anymore for post operative, and you could really see the difference between those. And if they decided to do any follow up checks, it would be great for comparison with that. The computed tomography, the CT scan, is great at demonstrating the bony structures in clear detail and diagnosing conditions with blood vessel involvement. So this granuloma was really close to the internal carotid artery. It was in the temporal bone, the petrous portion of the apex on the right. And so it's really good at localizing specifically where the lesion is within the skull. And so the professionals can work together and conduct intraoperative navigation in order to remove that lesion. And so I'll tell you a bit more about how that works, or Emily will give you a little quote on it.
Yes, this is a quote that supports the importance of the CT and the MRI. This quote states, currently, CT or MR imaging with a multiplanar reconstructions is used preoperatively because of higher anatomical resolution. If necessary, CT or MR imaging can be used to obtain isotropic, multiplanar, high resolution, thin section images of the head with optimal vascular and tumoral enhancement. So basically, this quote is stating that both of these imaging techniques can be used and are essential for picturing where this tumor is in the head. It can further lead the individuals to where to and how to surgically remove it. The CT imaging is essential for preoperative planning, and this can be combined with the MRI during intraoperative navigation. Um, in addition, it allows for the identification of bone thickness, extensiveness of the lesion, along with any other anatomical landmarks necessary. So this is very crucial, and Maggie will talk more about it.
Yep. So here we have an example of that imaging working with the endoscopic surgery in practice. So you'll see that we have the intraoperative photograph of a specific surgery performed with a monitoring navigation system called a CAS system. So this little computer workstation is mobile, so you can position it near the operating table. You see on the left, you have the CAS system information with the CT imaging and the endoscopic correlation. So where the endoscope is in relation to those different landmarks within the skull. And then on the right, you have the real-time endoscopic view. And so these images work together. You can have MRI, CT working together to really localize that lesion and figure out where to go during surgery so that you're making the best use of your time and you're preserving all the different areas around the granuloma while just really pinpointing it and removing it. So that's a really cool use of the imaging for this specific study. And so this team of professionals is working together to diagnose, treat, and monitor this condition ongoing. So we start out with the otorhinolaryngologist, the ENT, which is likely the first person this individual went to see in order to be diagnosed with the or at least get a hold of their symptoms, understand what was going on there, and then be referred to an audiologist for a hearing test, being diagnosed with a mild sensory neural hearing loss in that right ear, and putting that together with the results from the head impulse test, going on to get imaging from the radiology technician, which then the radiologist assesses and determines there is in fact a lesion. So all this together, they suspect there's a cholesterol granuloma, and this requires the attention of the neurosurgeon paired with the otorhinolaryngologist and the anesthesiologist to complete surgery and remove it safely and effectively, and followed up by some more imaging and hearing test to determine that the lesion was safely removed with no further complications, and it even restored the person's hearing to within normal limits in that right ear. So overall, just a really stellar example of how different professionals work together to monitor, assess, and treat a patient. And yeah, so that's what we have for this case study.
Yeah. Thank you so much. I hope you really enjoyed this case study. We are really looking forward to answering any and all of your questions that you post on the Blackboard discussion.
And here we
And
have
here are just our references and the credits. Thank you.